Evening. Happy Thursday. Tonight we are starting on the urinary system. The test for the respiratory system is already open and it is due by Monday at 11:59, just before midnight. Everything from that review PowerPoint from last week that I posted up is everything you need to know for the test next week. No, material from the lab exam will not cross over. It's just everything that's in that review PowerPoint is directly from the test. Let's start looking at the urinary system. We have this week and next week to cover just the renal system. And then the following week, we will do acid-base balance and electrolytes and fluids before we have our next exam. I will go over the practical for the urinary system in lab on Tuesday, as it's going to be a little bit different just because it was supposed to be on a day where there's no school. So I'll go over that more on Tuesday. What do our kidneys, what is their main job? Well, they help to kind of maintain that homeostasis within our system because they're going to regulate the water volume in our body. Can't have too much or not enough. Even the amount of solutes, those get monitored by the kidneys. Ion concentration. We have ions in our blood, and all of that gets monitored and either excreted out or collected back in to the blood by the kidneys. They're going to maintain that acid-base balance. Of course, our kidneys are a way to get rid of wastes, toxins, drugs. Even if you take too many vitamins, water-soluble vitamins, you excrete those out. If you don't need them, if you're more than what your body needs, sometimes I tell people they have some really expensive pee. Your kidneys produce erythropoietin. I know we had mentioned it before in other chapters, but erythropoietin is what helps to regulate your blood pressure because the kidneys need to maintain the pressure of blood that is coming through them so the kidneys can filter them. They also produce renin because all of the blood cells in our body go through the kidneys. We need to know when more red blood cells need to be made. We'll activate vitamin D in our system, and it'll carry out gluconeogenesis. Gluconeogenesis is turning ATP, or our cell's form of energy, back into glucose. So it's a reverse process. Our kidneys are part of the entire urinary system, of course. Off of the kidneys will come ureters. These ureters take urine down to the urinary bladder. And from that urinary bladder, the urethra provides the transport for urine out of the body. So here is our urinary system We have our right and our left kidneys here. We have our renal artery that comes in right off of that abdominal aorta. We have our ureters coming down off of the kidneys. We have our urinary bladder with the urethra coming off of the end. For those of you who have had children, you probably have experienced it, how that uterus sits right on top of the bladder and puts pressure down on the bladder as the growing fetus gets larger. So here is a view from a cadaver. We don't have we'll be able to see the kidneys in the cadavers on Tuesday. They took out all of the intestines, which makes a lot of this easier to see. Since all of our cadavers have all the intestines still in it, we can get to the kidneys, but it's really hard to get to much else just because there's so much packed in that abdominal area with all of the intestines still in there. You can see this cadaver has the 2 kidneys with the renal artery more behind the renal vein. And the renal vein goes back up into that inferior vena cava. We have our ureters coming down to that urinary bladder that's actually been sliced open so you can see the inside. Let's look at the kidneys in more detail. We'll go through the gross anatomy and we'll go into the microscopic anatomy of the kidneys. Our kidneys sit what is called retroperitoneal. They're technically considered that superior lumbar region. So they kind of sit at that T12, between the T12 and the L5 region. The right kidney is a little bit lower than the left, thanks to the liver. And on top of each kidney, we have those adrenal glands, which we looked at in the endocrine system. They have a convex and a concave side. We have a renal hilum, which leads to, we have the ureters, the blood vessels, we have lymphatics, nerves. So here is how the kidneys sit in the body. Because I know I'm pretty sure I've mentioned to some people in here that they kind of sit, they do sit right around that 12th rib usually. So they're kind of protected by those floating ribs in the back of that rib cage. So those floating ribs are at T11 and T12. So they're all protected down in that area of any kind of blows to the posterior portion of the body. We try to protect them because they are behind everything else. Here is showing how we have that perineal cavity. The kidneys sit behind that whole perineal cavity. So they're sitting in here behind the whole cavity, your whole abdominal cavity, which is the perineal cavity. That's what it means when they're retroperitoneal. They're behind that peritoneal cavity. Just like everything else, our kidneys have layers. They have a renal fascia, That's what helps kind of connect that outer layer of the kidney to kind of connects to that kidney. We have a perennial fat capsule, something else that helps to protect the kidney because it sits in a cushion of fat. We have a fibrous capsule, and it is a capsule that's going to prevent the spread of infection to the kidneys. We're trying to protect everything. Our body has ways to try to protect everything. Keyword is try, and it does its best, the best it can. So here was that retroperitoneal picture. So as I said before, and with that picture, that those kidneys are protected by that thoracic cage and fat. The lower part of the kidneys, depending on where the kidney sits in the person, especially that right kidney, is since it sits lower than the left because of the liver, it's more susceptible to having some kind of trauma. Falling flat on your back, car accidents, even sports injuries, getting tackled on that right side, getting a shoulder right into that right lower back. Our renal arteries can actually be injured pretty easily. Like a rapid deceleration during a car crash. That rapid deceleration, the car is going pretty quick, and then all of a sudden it hits something, so it stops really fast. That can actually cause a tear in that renal artery, or what is called a thrombosis. A thrombosis is a blood clot in that renal artery. And if a thrombosis or a blood clot gets stuck in there, it prevents the blood flow to the area, which can lead to all kinds of different problems. Can also cause hematuria. Heme for blood, urea, urine, so blood in the urine. So it's a sign. If you see blood in your urine after some kind of accident, it could be some kind of renal artery problem. And the only way to fix it, or one of the main ways to fix it really, is surgery. Surgery may be required to fix it depending on how much that artery is torn, which they have different ways to do imaging to check all of that stuff before they put you under the knife and cut you open before knowing what all is happening. So what can we see when we look inside of a kidney? This we can see without any kind of microscope. Of course, we can see the cortex. That is the most superficial region of that kidney. It's a part we're going to see directly on the outside. That renal cortex is going to make up this whole area through here, all the way around. We have a renal medulla. It's just below that cortex. And we have several medullary or renal pyramids. They're a cone shape. So every one of these cone things through here, this is a renal medulla. The papilla is technically the tip of the pyramid. and they're separated by renal columns. Well, those columns are the part here that's in between. These are those renal columns. We have within that renal medulla, we have a lobe, and it is the medullary pyramid and its surrounding cortical tissue is what it is. There's about 8 lobes per kidney. I mean, this drawing here has 7. The real kidney, the cadaver kidney has could be 8 in there. So it's not always going to be 8, but it's around 8, 7, 8, could be 9. We have a renal pelvis. That is the funnel portion that comes out. So this portion through here is that renal pelvis. And it turns into the ureter that takes urine down to the bladder. We have a minor calyce and a major calyce. The minor calyce is where the area where urine is collected. Get a different. Like here is that minor calyce. Here's another really good picture, minor. You can see it well here. These are all those minor calyx. Then that major calyx is more the wider area that opens up from the minor calyx. Can we see what the lobes are? I'm not sure I understand what you're asking because we're going to go down to microscopically what makes up each of the lobes. But this is still what you can see with the naked eye. These are all the parts when we look at a kidney, what we can actually see. And then we're going to get into microscopically what everything looks like. We see the 8 lobes. We have one coming through out here. You can kind of see 1, 2, 3, 4. Looking exactly where these, because here's another. That one leads to another one. And even this over here. It's the darker regions that come together to form. How can we tell the lobes from the medulla? Let me erase my picture and I can show you over here on the drawing. So that renal medulla is technically this portion through here. So the whole thing is the renal medulla. Versus the renal pyramids is just this portion. Through there. There's different kinds of infections or inflammations that affect parts of the kidney. Pyelitis affects just the pelvis and the major and minor calyxes, while pyelonephritis involves the entire kidney. It's more common in females to get pyelonephritis just because of where the urethra and the anus sit so close together that fecal bacteria can enter through that urethra and actually travel up to the kidney and cause an infection. That's where your kidneys can start swelling. You can form abscesses, and pus can fill that renal pelvis. Can lead to kidney damage if nothing is done, but the nice thing is it pretty easily can be treated with antibiotics. So the blood supply to our kidneys. Of course, our kidneys' job is to filter and clean the blood. It can also adjust the composition of the blood. We have too many ions, not enough ions. If we have too many proteins, not enough proteins or amino acids, all of that gets filtered in and out through our kidneys. Our renal arteries, they get about a quarter of what your heart pumps every minute is going through our kidneys. So that's a lot of blood filtering through the kidneys every minute. So as the blood travels through the kidneys, they travel through different routes. The different routes that they are going to take is it starts at that renal artery coming into the kidney. It'll go to segmental arteries, interlobar arteries, arcuate, cortical radiate or interlobal, lobar. Then they're going to go through even more. They're going to go through an afferent, glomerular, arterial. Then they're going to go through glomerular capillary. From there, they will go through the efferent glomerular arterial before they start hitting the venous flow. They're going to hit peritubular capillaries, then peritubular venules, to comes all the way up to cortical radiate arteries, to arcuate or cortical radiate veins or venules, to arcuate veins, to interlobar veins, to renal veins. So there's just some capillaries that we're not quite in there, but we're going to go through exactly how this capillary flow works, because that is where all the filtration actually takes place. We have sympathetic fibers from a renal plexus is what innervates our kidneys so that our brain knows what is happening at all times. So here is part of that blood flow as everything comes in through that renal artery, and then it is going to travel out to segmental arteries, to interlobar arteries, to arcuate arteries, to cortical radiate arteries, and then it goes through a bunch of capillaries and arterioles. We have the afferent glomerular arterioles, glomerular capillaries, efferent glomerular arterioles, peritubular capillaries, to peritubular venules, to cortical radiate veins, to arcuate veins, to interlobar veins, then back out our renal vein. So that's the entire pathway that these blood vessels are going to go through. We're going to break down the smaller ones in a little bit. That's where all those, what I just wrote down before, it's here on this slide, because we go to cortical radiate to afferent glomerular arterioles to glomerular capillaries to efferent to peritubular capillaries, or this or vasa recta. Vasa recta is the other part of capillaries I'll show, to cortical. This is the entire pathway through here. Now let's get into the microscopic portion. This is the part that we cannot see without some kind of microscope. And these parts are where different filtration and reuptake takes place. Because we filter out a lot of stuff, but then depending on what our body needs, a lot of it actually gets taken back up. So we'll go through a lot of that process. We have nephrons. That's what actually forms our urine. We have more than 1 million nephrons per kidney. That is a lot. And the nephrons are made up of the renal corpuscle and the renal tubule. We have two parts to our renal corpuscle. We have that glomerulus, the bunch of capillaries that are fenestrated. So remember back to the cardiovascular chapter when we looked at the different kinds of blood vessels. These are capillaries that are fenestrated. So they have almost kind of look like they have holes in them. They look like Swiss cheese. They allow filtration of the blood and the plasma as it travels through this glomerulus. And we have what is called filtrate at this point, which is plasma. And that plasma is what helps to form urine. The glomerular capsule, or Bowman's capsule is the other name for it. It's kind of looks kind of like a cup because it's this right in here. It has that parietal layer, simple squamous epithelium, and it has a visceral layer. And that visceral layer surrounds the capillaries that are inside the glomerular capsule. There's cells that are called podocytes. These podocytes over here, they have like these little foot-like projections that kind of help to, or they attach to that visceral layer. So it attaches to the layer that attaches to the capillaries to help filter the blood as it comes through. What is it? It has filtration slits. It allows the plasma and the blood to completely be filtered. So here is the nephron, this whole part through here. We have a capillary. You can see the glomerulus in there. It is capillaries. Is this whole portion through here. This is all just a big bundle of capillaries that blood is filtering through there, and it's getting filtered in this renal corpuscle. And what's being filtered out goes into that glomerular capsule, which will exit that renal corpuscle and head off to the nephron. Eventually it'll go through that nephron loop. And we'll go through that whole process. So you can see the glomerular capsule. It's a layer of simple squamous epithelial cells. And that's that parietal layer. And here's a better picture, not as blurry. You see that podocyte cell, you can see it has all these little feet that attach to that basement membrane. And then that fenestrated capillary is just underneath it, and that is where this is where all the filtration of the blood is taking place. So the renal tubule is about 1.2 inches long. It's a single layer of epithelial cells again. But there's different parts to it, and each part has its own function and histology. I will give you guys the lab sheet on Tuesday for the urinary system, and I have written down exactly what histology you need to know, because histology will come out once again. So the different parts of the renal tubules that each one has its own function. In histology, we have proximal convoluted tubules. It's proximal because it is the closest to those renal corpuscles. Thinking about our anatomical terms, proximal means closest to. We have that nephron loop, which is that whole part that we saw in that picture that went back down and back up. Then we have the distal convoluted tubule. Again, it's distal because it is the furthest part of that nephron away from the renal corpuscle. It says where it's located in conjunction to that actual corpuscle, which is kind of nice. Then we have our collecting duct, and that is at the end of that distal convoluted tubule. That collecting duct is where urine is collected. So let's look at each part so we know what kind of cells to look for. So that proximal convoluted tubule is cuboidal cells. They have microvilli. Remember, those cuboidal cells are kind of that cube shape, but they have lots of microvilli on them. So that's my cuboidal shape. Microvilli, its main job is to increase the surface area of that cell. So every place where those microvilli go up and down, that is just increased surface area for that cell, because that is all places that come in contact with what is being filtered. They have a large mitochondria. That is where they create their energy. The proximal convoluted tubule is going to do some reabsorption. It's going to take back in some of the stuff that was originally filtered out by that renal corpuscle or that glomerulus. We're only going to find the proximal convoluted tubule in the cortex. We are not going to find it anywhere else. So here is your book's drawing of this proximal convoluted tubule. You see all the little, I guess they're orange parts in there that have, those are all mitochondria with those little finger-like projections at the top. Those are those microvilli that increase the surface area to help reabsorb, but it also secretes. The nephron loop. I learned it as the loop of Henle. This shows how often they like to change names, because that was only about 4 or 5 years ago. Maybe 5. About 5 years ago is when I learned it as the loop of Henle. So it really wasn't that long ago it had that name. But it is that U shape. That nice U-shaped tube. We have a descending limb. Descending because it goes down. It is continuous with the proximal tubule. So it goes straight from that proximal tubule to the descending limb of that nephron loop. It is our simple squamous epithelium because that is the easiest type of epithelium for filtering. We have an ascending limb. That is the portion going back up. It's cuboidal or columnar cells in this area. So here is a thin segment of that nephron loop. You can still see it has lots of little projections coming off of it. They're not large enough to be called anything specifically, but it still increases the surface area of what that cell has contact with as that filtrate is going through that nephron loop. The distal convoluted tubule. Again, we have more cuboidal cells, but they don't have as much microvilli on there because they're secreting. They're not necessarily absorbing, they're more secreting. And again, they are found in the cortex. This is our distal convoluted tubule of that nephron. You can see there's not as many projections coming off of these cells because they don't need as much surface area to reabsorb because they're mostly secreting. So here is some histology. This is directly from your book. Should be in your lab manual. I know it's on PAL, but you can see the renal corpuscle. You see the glomerular capsule, capsular space, and that glomeralis. So this whole portion in the middle here is that glomeralis. We have that renal corpuscle is this whole portion through here. Then you have that capsular space in the middle where stuff that's been filtered out from all these capillaries in here, that's where it goes. You can also see the proximal convoluted tubule, which is this portion through here. You see the difference? These are all proximal convoluted tubules. They're staining darker, while the distal convoluted tubule will stain lighter. You can see the different colors in them. So I circled them in different colors so you could see the difference between the renal corpuscle, the proximal convoluted tubule, and the distal convoluted tubule. And yes, being able to identify the renal corpuscle, the glomeralis, proximal convoluted tubule, and the distal convoluted tubule is important. Practical reasons. Our collecting ducts. That is the next portion off of that distal convoluted tubule. It will empty out into a collecting duct. Our collecting duct has two types of cells, principal cells and intercalated cells. Principal cells have some microvilli. Their job is to make sure that we have a water and sodium balance. The intercalated cells, cuboidal cells with a lot of microvilli. They work to maintain that acid-base balance in the blood, because our kidneys help maintain all of this. So those collecting ducts, as I said, they collect from that distal convoluted tubule that empties into that collecting duct. That whole distal convoluted tubule is part of a nephron. So those one collecting duct will receive that filtrate from several nephrons. Not just one. There's not one collecting duct per nephron, because we said there were millions of nephrons. So one collecting duct connects to several nephrons. And that's what runs through those medullary pyramids. And that's why those pyramids have a striped appearance. Those collecting ducts are going to come together. And they will take that urine that goes through that renal pyramid and release that urine into the papilla and into that minor calyx that goes to the major calyx that'll go to that renal pelvis, which goes to the ureter. So here's the two different kinds of cells. You can see that principal cell versus the intercalated cells and how they differ in color and features. So here's this whole nephron again. So as blood comes into the renal corpuscle, we get that glomulus, which is a bunch of capillaries. They get filtered. What gets filtered out goes into that proximal convoluted tubule. It'll travel down to the descending loop. It comes down, it goes down the descending loop. And then it'll go back up the ascending loop. Once it comes back up, it goes to the distal convoluted tubule, which drains into that collecting duct. So we have two different kinds of nephrons. And we get down to a full microscopic view of everything. We have cortical nephrons and juxtamedullary nephrons. Most of our nephrons are going to be cortical because that's almost the entire cortex is made up of just cortical nephrons. So here you can see our cortical nephron is this whole part through here. That is a cortical nephron. juxtamedullary nephron is this part that goes all the way down and back up. That is our juxtamedullary nephron. There's a lot longer of a nephron loop here. It goes all the way down to the medulla. The ascending limb will have a thick and a thin segment, and that helps to concentrate our urine. Let's say yes, they do show it. That thick and the thin segments, so you can see through here, this is coming back up. This is the thick segment through here. Well, here starts the thin segment portion. There, and then we have the thick segment coming through there again. So those are the thick and the thin segments of this specific, of the juxtamedullary nephron. It still functions the same because we still have, let's try to figure out what color to use. This glomeralis here, where capillaries come in, that makes that glomeralis, so that renal corpuscle, they get filtered. The filtrate comes out into the proximal convoluted tubule to that nephron loop, to the distal convoluted tubule that goes into the collecting duct. So it still works the same. It's just one has a longer nephron loop while the other one does not. Here is another difference. If you see all these capillaries that go through that proximal and that distal convoluted tubule of this cortical nephron, they have what are called peritubular capillaries that surround them. While the juxtamedullary nephron has vasa recta, which are these capillaries along the length of it. So the capillary names are different depending on the nephron. So I just showed it on the picture, but here it is in writing. So those renal tubules are associated with that glomeralis, which is the capillaries that feed that renal corpuscle. Peritubular, and then that vasa recta that goes to the juxtamedullary nephron. Let's look at what makes up this glomerulus. So we're getting even smaller. We said those are those fenestrated capillaries that is inside that glomerulus, the one that kind of looks like Swiss cheese. They are made up of an afferent arteriole. Afferent goes in, and an efferent arteriole that goes back out. So if I have that capsule here, the renal corpuscle, I have my afferent that comes in, and it does all kinds of twisting all over the place, and then my efferent that goes back out. And then we get our afferent arterioles, come from those cortical radiate arteries. And then the efferent go to either those peritubular capillaries that goes around that nephron loop or the proximal and distal convoluted tubules, or the vasa recta of this juxtamedullary. So it goes here or here once the efferent arterial feeds out into here. It's like here the efferent arterial feeds all of this. So once it's been filtered in that renal corpuscle, it goes back out and it follows those proximal and distal convoluted tubules and or that nephron loop. We need to maintain a high blood pressure through that glomerulus. So our afferent arterial is going to be larger. That's what I wanted. So we're going to have a lot larger feeding in than what comes out. If we remember from our cardiovascular chapter, arterials are very high resistance vessels because as the blood vessels get smaller and smaller and smaller, it increases in resistance because there's less space for everything that's inside that vessel to flow. So that's what kind of builds up some of that resistance. Well, as these arterioles are going into and coming out of this glomerulus, they need to maintain that high resistance to maintain that higher blood pressure. So once we hit that efferent arterial that comes out of that glomerulus, we go to those peritubular capillaries or that vasa recta. Those peritubulars, they're low pressure. They're still porous capillaries because we need to reabsorb some of what's been excreted out. Because our final end product, we only excrete out the final end product of like about 1% of the plasma that has been filtered is what's actually excreted. We'll go into detail about how to find that, but just to kind of give you an idea, because as we go through this glomerulus, all those capillaries that go through there, it originally will filter out, this up here will filter out about 20% of the plasma in our blood. 19%, that's about 19% of it gets reabsorbed back up. And that's taking place in these peritubular capillaries, in the vasa recta. We are reabsorbing what was just filtered out. And then from the peritubular capillaries at the end of this whole process through here of winding, intertwining between those proximal and distal convoluted tubules, they are going to empty out into venules. And the venules work their way back to the renal vein that works their way back. The renal vein goes to the inferior vena cava, which goes back to the heart. The vasa recta. They run along that nephron loop of the juxtamedullary nephron. Again, they come from those efferent arterioles, just like the peritubular capillaries do. And I know we said it on a slide or two ago, but their function is to form concentrated urine. So they're going to work to make sure that we're not excreting more water than we need, but we're excreting just the products of what we need. What our body does not need anymore is a better way to put it. That is the main job of those juxtamedullary nephron and that vasa recta. So here's a really cool electron micrograph. Sorry, I really like electron micrographs because they show such a good picture of what is happening. So you see all the blood vessels in red and kind of this lighter pink color. You see the glomerulus through here. And that's just a capillary bed that filters out. You see the afferent arteriole that's going into one of these, how much larger it is than the efferent arteriole that is coming out. So this is just a really cool picture of what's actually happening in our kidneys right now. So here's that same picture from before, just showing the different parts as everything comes together to form urine. So each nephron has what is called a juxtaglomerular complex, or JGC. There's parts, we have the distal portion of the ascending limb of the nephron loop in there. We have an afferent arteriole, not always an efferent arteriole, but it helps to regulate our filtering of everything in the blood. It also regulates our blood pressure coming through the kidneys and what the blood pressure that's going into those glomerulus. Because, of course, we need to maintain a high blood pressure coming in to help filter. So that juxtaglomerular complex has a macula densa. We have granular cells and extraglomerular mesangial cells. That is what makes up this juxtaglomerular complex. So this macula densa, it's a bunch of cells in the ascending limb. So that ascending limb, it's going back up. Just like in our respiratory system, we have chemoreceptors that's going to help monitor oxygen in our blood in different areas. We have chemoreceptors in our kidneys, and that is part of that macula densa, because we need to check the sodium chloride that's being filtered out, because we don't want to be excreting too much sodium and chloride or not enough. We may have too much in our system, so we have to monitor what's going on. Granular cells, part of that smooth muscle, of arterioles. Those mechanoreceptors, they're going to detect the changes in shape. So they're going to sense the blood pressure in the afferent arteriole. Because every time that blood pushes through, it senses a bit of stretching. And they also secrete the renin, the extraglomerular mesangial cells. They're between the arterial and the tubular cells. They have gap junctions, which allows the cells to talk to each other. So they can pass information between that macula densa and those granular cells. They need a way to communicate with each other. So here is this entire complex. Juxtaglomerular complex. We have that afferent arteriole coming in. We have these granular cells. All these cells along this afferent arteriole that's coming in. We have this macula densa cells through here. That is part of that ascending loop that's coming back up because we need to monitor sodium and chloride levels that have been through that descending loop. It's coming back up the ascending loop. We need to check the concentration levels. Those extraglomerular mesangial cells are this portion in here that help to communicate between the granular cells and the macula densa. We need to maintain the blood pressure of the blood coming in to this renal corpuscle. So this is what's all going on, kind of monitoring everything going on as it goes. That afferent arteriole comes into that renal corpuscle, into the glomerulus, which eventually feeds back out to the efferent arteriole, which goes to the proximal convoluted tubule, down the nephron loop, the descending and the ascending portion of that nephron loop to the distal convoluted tubule. And then that ascending loop, as everything's coming back up, it's getting monitored. What's still in this filtrate that may need to be filtered out or be reabsorbed back in, or what can we keep in there to get rid of? So our kidneys, they filter 180 liters of fluid a day. So they do all kinds of, they filter constantly. As you're just sitting here, they are filtering. They're always working. Only about 1.5 liters actually turns into urine out of that 180 liters. That's less than 1% of everything that goes through. We filter our entire plasma volume 60 times a day. That is a lot. And when you're at rest, like right now, only 20 to 25% is being consumed by your kidneys. This filtrate we've been talking about, it's your blood plasma without the proteins. And we take that filtrate and produce urine. I said it's less than 1% of that original filtrate turns into urine. We're getting rid of wastes, unneeded substances. Water-soluble vitamins our body's going to get rid of. Fat-soluble vitamins get stored. But these water-soluble vitamins that your body doesn't need are going to get excreted. Too many amino acids, they're going to get excreted. Too much sodium, it's going to get excreted. All of this goes through this process as your blood gets filtered 60 times a day. So there's 3 different processes that happen as your blood gets filtered and urine gets formed. We have the glomerular filtration, which we've kind of been talking about. It's just plasma. There's no cells, there's no proteins at this point. And that glomerular filtration, it's just plasma being filtered. Tubular reabsorption. %99 gets returned back from that filtrate to the blood. Then our tubular secretion. That's where substances move from the blood to the filtrate. It happens in the tubules and the collecting ducts. So we need to sometimes get rid of more than just plasma. We have other things to excrete from our body. So we need to get rid of it somewhere. And that happens in that tubular secretion. So here's the different steps. We have that afferent arterial coming in. That is that glomerular filtration. 2 is that tubular reabsorption. So we have turned this into it comes out of the glomerular capsule down into the proximal convoluted tubule with these peritubular capillaries that are going to reabsorb. We are also going to have tubular secretion that is happening to get rid of wastes. Of course, it's a passive process. It doesn't require ATP to happen, because if it required ATP, we need to find a whole lot more ATP just to make filtrate to process into urine. So it relies on hydrostatic pressure that pushes things in and out of the filtrate in the capillaries and the tubules. That's what causes the creation of urine. So we use that hydrostatic pressure in that glomerular capsule specifically. We do not do any type of reabsorption in the glomerulus. It is straight filtering out at this point. Nothing comes back in. It is straight filtering out. So that filtration membrane, it has to be porous, because how else are we going to get specifically solutes out of our capillaries, out of our bloodstream? Because we need a way for everything to get in and out the way it needs. We have to have pores in there somewhere. So we have a fenestrated endothelium. That's just those glomerular capillaries. We saw that picture before. We have a basement membrane that attaches to those glomerular capillaries. And then we have those podocytes. And they have slits that help filter out the plasma. We have slit diaphragms that allows any kind of larger solute to stay in our blood. We filter out small solutes, but we will not filter out any of the larger solutes or macro molecules. Macro is large, so we don't filter any of those out. So we've looked at this picture before, the renal corpuscle, the afferent arteriole going in. We see all those podocytes attached to these capillaries. Those are those podocytes. And they create these slits that allow for filtration of plasma, most small, very small solutes. So we have those fenestrations in there in the capillaries specifically. Draw those little holes that allows for plasma to be filtered. Then here's a cool electron micrograph of a podocyte attached to that capillary for filtration. You can't even really see the capillary in there because of the podocyte, but there's little teeny tiny slits that allows things to be filtered. So here is that filtration membrane. We have that capillary with those fenestrated pores in here. The basement membrane in the middle with these podocytes. On the other side that has little slits for filtration. Once in a while, macromolecules kind of get stuck in that membrane. We have what are called glomerular mesangial cells. And these are going to kind of take up any of those macromolecules that get stuck. Because we only want to filter out small particles. We want to filter out water, glucose, amino acids, nitrogenous wastes. These all get filtered out because they are smaller than 3 nanometers. Those proteins are going to remain in the blood because we need to maintain osmotic pressure in our blood as well. But those plasma proteins also help to prevent the loss of all water because we don't need all the water with the plasma in our blood to be filtered out. We need to keep enough of it in there to keep our blood flowing. if we end up with larger proteins in our filtrate, that means there's some kind of problem with the membrane that prevents these proteins from filtering through. What about outward pressures? Because we need a way that form this filtrate. So, as I had mentioned, there's a hydrostatic pressure. That hydrostatic pressure keeps the blood pressure going through those glomerular capillaries high. It's about 55 millimeters of mercury going through those glomerular capillaries. That's pretty high for a very teeny tiny capillary, because that's what helps to push water and solutes out of the blood into that glomerular capsule that drains into the proximal convoluted tubule. Most capillary beds are about 26 millimeters of mercury. That just kind of gives you an idea of how high it is in those glomerular capillaries versus other capillaries. Why is the pressure so high besides filtering things out? Remember how that afferent arteriole was big going in and the efferent arteriole was smaller coming out? Well, as it gets smaller, as those blood vessels get smaller, the resistance gets higher. So they need to be able to push the blood through those high resistance blood vessels. And that's what helps to keep that hydrostatic pressure as high as it is. So what affects our inward pressure that prevents everything from leaving our blood? Because there's a lot of things in our blood and we need to prevent some of that from leaving. So we have hydrostatic pressure in the capsular space and colloid osmotic pressure in the capillaries. So the hydrostatic pressure in the capillary space, it's only about 15 millimeters of mercury. It's pretty low. And that's the filtrate that has already been filtered out of those glomerular capillaries. And it's in that renal corpuscle, it's in that glomerular space before it gets drained into that proximal convoluted tubule. We have colloid osmotic pressure in capillaries. And that colloid, it's a little bit higher, but because of this colloid osmotic pressure, it keeps those proteins in the blood. The net filtration pressure is actually that hydrostatic pressure plus that colloid osmotic pressure. So it's the sum of forces. Which is about 10, because we have our net filtration rate is what is outward, technically, that outward force of 55 millimeters of mercury minus the inward force, that force opposing, which is the sum of that hydrostatic and that colloid, 15 plus 30, gives us that 45. So that's where that comes from. So 55 minus that 45 creates a net outward force of 10 millimeters of mercury. And that is that pressure that is causing that filtrate to form. And that is all considered the glomerular filtration rate. Is this 10 millimeters of mercury? So here's a picture showing all those forces. We can see the hydrostatic pressure is 55 millimeters of mercury versus that osmotic pressure plus the inward hydrostatic pressure of 15. We take the hydrostatic pressure of 55 millimeters of mercury minus the hydrostatic pressure and the osmotic pressure. Add those together, get the 45, which gives us that net filtration pressure of 10 millimeters of mercury. So our total glomerular filtration rate is how much filtrate is being formed per minute. We are technically making 120 to 125 milliliters per minute of filtrate. Of course, it's going to be proportional to different things. Again, it's going to be proportional to the filtration pressure, the total surface area available for filtration, and then the filtration membrane permeability. So that net filtration pressure, that's the main pressure in the glomerular hydrostatic pressure, because that's what's pushing out. The total surface area, well, remember those glomerular mesangial cells? They help to kind of monitor what's going on, allow cells to communicate with each other. They're going to cause contraction of those cells to that afferent arteriole. And that's going to cause the different, it's going to either increase or decrease that pressure going in to that glomerulus. Then the filtration membrane permeability. Of course, our capillaries going through the kidneys, going through that glomerulus need to be a lot more permeable to different things. Because we need to be able to filter out our blood, filter out what we don't need. So they have to be able to, these capillaries need to be able to perform that specific task. So we need to maintain this glomerular filtration rate because it's going to make filtrate, but it's also going to maintain our homeostasis. We need to maintain our body's homeostasis. We need to maintain these controls over our pressure over our kidneys as it filters. Because we have intrinsic controls and we have extrinsic controls that all control this glomerular filtration rate and tries to keep it somewhat steady. So these intrinsic controls, intrinsic means it's inside the kidney specifically. Versus the extrinsic is controls outside the kidney. So we try to maintain that glomerular filtration rate as our intrinsic control. But that glomerular filtration rate, it's going to affect our entire system's blood pressure. So if we increase our glomerular filtration rate, it causes more urine output. If we have more urine output, it lowers our blood pressure. If we have decreased urine output, it's going to increase our blood pressure. So our extrinsic controls try to maintain somewhat of a steady systemic blood pressure. Of course, just like every other system, our nervous system's going to play into that, and our endocrine system's going to play into that. Because again, their goals are to maintain our glomerular filtration rate to help maintain our system's blood pressure. So again, our intrinsic controls, we need that constant glomerular filtration rate. So it usually stays between 80 to 180 millimeters of mercury. If it's outside that range, our intrinsic controls cannot regulate it anymore. So we have a myogenic mechanism and a tubuloglomerular feedback mechanism. That myogenic mechanism. Myo means muscle. We're in the kidneys, so it can't be skeletal muscle because we don't have control over it. So it has to be smooth muscle. Smooth muscle, when it gets stretched, it will contract. That is one of the ways smooth muscle works throughout our entire system. As it gets stretched, it signals the cells to contract. The nervous system doesn't need to tell the smooth muscle cells to contract. They will do that on their own. So by contracting these smooth muscles, cells, it will help to, if we have increased blood pressure, the muscle cells are going to stretch. And as these muscle cells stretch, they're going to contract and constrict or make those afferent arterioles going into that glomerular capsule to the glomerulus smaller. Blood flow to that glomerulus goes down. So if we have too high of blood pressure, it can damage those capillaries in that glomeruli. So we constrict those afferent arterioles to slow down the pressure coming in so we don't damage that glomerulus. If we have a decreased blood pressure, those smooth muscle cells are not being stretched as blood comes through, so it causes dilation of those afferent arterioles. So they get bigger. And as they get bigger, more blood is allowed to flow into that glomerulus to help maintain the pressures going through. So this myogenic mechanism can respond to changes in blood pressure. What about this tubuloglomerular feedback mechanism? So this has to do with those macula densa cells that kind of monitors that area around that ascending portion loop of that nephron loop, because they're looking at that sodium chloride concentration. So if our glomerular filtration rate goes up, so we have more filtrate being formed. We're having more filtrate being formed. We're not going to be able to reabsorb as much stuff. And if we're not able to reabsorb as much going through those proximal and distal convoluted tubules or through that nephron loop, we're going to have a lot more sodium chloride levels in the filtrate because everything is moving too fast for us to take back what we need. That is going to cause a constriction to that afferent arteriole, slow things down. We need to slow things down so we can filter out the sodium chloride that we need. It gets put into the filtrate, we filter it back out because we need it back. We need sodium and chloride in our system for pretty much every cell in our body to function. And it's opposite for a decreased glomerular filtration rate. So if that filtrate coming through is moving too slow, what's going to happen is that afferent arteriole is going to constrict. Or no, it's going to get bigger. Sorry. It gets bigger, so it allows more blood to go through, pressure to go higher. So that filtrate coming out goes through faster. So we can, because there may be too much sodium chloride being reabsorbed from that filtrate. So that is what causes that afferent arteriole to dilate. So everything can go through quicker so we don't filter out as much. So how does our nervous system and our hormones respond to this? Our extrinsic controls want to maintain our system's blood pressure. As we don't need our system's blood pressure jumping up, going down, jumping up, going down, kind of doing one of these things all day long. So we try to keep it pretty steady throughout the day. So our extrinsic controls will actually override any of those intrinsic controls based off of blood volume. So our sympathetic nervous system causes these blood vessels to be more dilated when you're in normal resting conditions, like right now. Because we're going to keep our auto-regulation mechanisms in check. What about during abnormal conditions? What if we have very low extracellular fluid volume? So we have low blood pressure. Norepinephrine from our sympathetic nervous system, as well as epinephrine. They're released from that adrenal medulla. So we get that epinephrine and our norepinephrine into our blood. That triggers more of that fight or flight type of response, which that fight or flight response tends to constrict. Constricting increases our blood pressure. It'll constrict those afferent arterioles, which actually decreases the glomerular filtration rate. We get more plasma in our blood, so we have more blood volume. And if we have more blood volume, pressure is going to increase because it takes more to push that increased blood volume through our system. That's all done by our sympathetic nervous system. We've looked at this system before, the renin-angiotensin-aldosterone mechanism. So let's look at exactly what it does in the kidneys now. As we looked at it in the cardiovascular system, because it's a specific mechanism to increase the blood pressure. So we could have stimulation of the granular cells by the sympathetic nervous system. We could have it stimulated by the macula densa cells because we don't have enough sodium chloride in our filtrate. It's too low. Those granular cells aren't being stretched, which triggers either constriction or dilation of that smooth muscle. So here's a really nice chart that shows what happens in our system in different areas based off of a decreased systemic blood pressure. So if we have a decreased systemic blood pressure, let's start over in the blue boxes, which a decreased systemic blood pressure is going to decrease the blood pressure in that afferent arterial, which is going to decrease glomerular filtration rate. Because that is decreased, there's a decreased stretch of that smooth muscle in the afferent arterioles. So those afferent arterioles are going to dilate, which is going to increase glomerular filtration rate. How about if we have a decreased glomerular filtration rate? So we have a decreased filtrate flow and decreased sodium chloride in the ascending limb of the nephron loop. Causes those macular-dense cells of the juxtamedullary capsule or complex in the kidney to vasodilate those afferent arterioles, which increases glomerular filtration rate. So we have a lot of different, those are intrinsic controls just to keep that glomerular filtration rate somewhat steady. And what happens when it gets too low or too high or too low, really. We have other ways to affect that glomerular filtration rate. because our kidneys release all kinds of chemicals. We have some chemicals that act on paracrines. Paracrines affect those renal arterioles. We have adenosine and prostaglandin E2. We also have some cells that like to make angiotensin 2, which kind of reinforce that whole renin angiotensin process of maintaining our blood pressure. So here is the summary of the glomerular filtration rate. The intrinsic controls or extrinsic controls, how it works. Like the intrinsic controls, it's going to work on that smooth muscle or those tubuloglomerular feedback. And it needs to keep a pressure between 80 and 180 millimeters of mercury versus that extrinsic control tries to maintain your whole system's blood pressure. We use hormones that run an angiotensin aldosterone system to maintain our system's blood pressure. We also have baroreceptors that work through our sympathetic nervous system because our extrinsic controls are going to work below 80 degrees or 80 degrees, below 80 millimeters of mercury and above 180 millimeters of mercury. That is when that extrinsic control becomes more pertinent, is when we're outside of the mean arterial pressure range for the intrinsic controls. Anuria. A means none or not much. Urea, urine. This type of person would have an extremely low urinary output. Less than 50 milliliters per day. That's very little compared. It's like a third of a normal person. That's about 150 milliliters of urine output per day. There's different things that can cause it. That glomerular blood pressure is too low. Renal failure. And anuria is where those nephrons stop functioning because of acute nephritis, a transfusion reaction, or crash injuries can cause anuria or renal failure. So there's a lot of different things that go into reduced urine output. So let's look at the second part of the entire nephron process. We have tubular reabsorption. That is where it does what it says. Returns things back to the blood. As we originally filter out more than our body requires. So we have to reabsorb quite a bit of stuff that we do not, or that our body does need. We have a transepithelial process. Almost all of our organic nutrients are going to be reabsorbed. How much water is reabsorbed, how many ions are reabsorbed, that all depends on hormones. We have an active and a passive process of reabsorption, and they can be done transcellularly or paracellular. So tubular reabsorption, it's going back into those capillaries or those arterioles. So let's look at the transcellular route. Transcellular, our solutes are going to enter the membrane of those tubule cells. So those proximal and distal tubule cells, those pathways, those cells and their solutes are going to enter the cells. They're actually going to go through the cytosol, and they're going to exit on the opposite side of those cells. So we get those different cells. It's actually going to go through right through the middle of the cell. Transcellular, going right through. From there, it's going to go right back into those peritubular capillaries. How about the paracellular? A paracellular is between tubule cells. So we have those cells, and there's little junctions or tight junctions where different ions, water is going to pass through. In that proximal nephron, it's more leaky. So things just easily travel through in that proximal convoluted tubule. That's where we reclaim water, calcium, magnesium, potassium, some sodium. That proximal convoluted tubule, and it moves into those peritubular capillaries at that point. So here's that transcellular. Right through the middle of that cell and back into that capillary. Versus the paracellular, it's going between the cells and back into that capillary. That's why we have all of these microvilli or finger-like projections, because it increases that surface area for more solutes, more ions, more water to pass through. So what about sodium? Sodium is, of course, going to be the most abundant cation. Cation means positive ion, filtered. So sodium is done via primary active transport. Sodium is, we also have sodium potassium ATPase pumps, and that helps to get sodium to the interstitial spaces, so between the cells, and that then is the sodium that gets pumped in between the cells will be swept back up into those peritubular capillaries. They can also enter those tubular cells by a secondary active transport or facilitated diffusion through channels. We also pump sodium because we have a strong electrochemical gradient in the tubule cells. Because we want to keep sodium in our blood is the main goal. So because of this sodium being pumped, results in low intracellular sodium levels. And if we have low intracellular sodium, it's going to diffuse because it likes to go from an area of high concentration to an area of lower concentration and kind of spread itself out around that entire area. Potassium leaks out of the cell into that interstitial fluid. We need potassium. Potassium and sodium kind of work opposite each other. So when one is going one way, the other one goes the opposite. It's how sodium and potassium always work. One goes one way, the other goes the opposite. So as potassium leaves that cell, it causes a more negative charge within that cell. And negative and positive, like two magnets attract each other. That more negative inside the cell will pull sodium in. That allows it to transport into the blood. So if we resorb sodium in that primary active transport, means we're providing energy. We're providing energy to reabsorb any other substances we might need. Like urea or glucose, bicarbonate ions even. Secondary active transport, we create this electrochemical gradient that helps to push other solutes back into those capillaries, like our glucose, amino acids, ions, vitamins. Those actually move more by secondary transport than active transport, but because active transport requires ATP to make it happen. Passive peritubular reabsorption of water. How osmosis works is where water moves from an area of higher solute concentration to an area of lower solute concentration. So as we're moving sodium, it creates an osmotic gradient for water, which causes us to reabsorb. If we're reabsorbing sodium, we also reabsorb water by osmosis. And we use these aquaporins to water pores that allows water to be filtered back into that bloodstream. We have aquaporins in the proximal convoluted tubule because we need to reabsorb water. We also have aquaporins in the collecting ducts. But they only work when that antidiuretic hormone is present. Those aquaporins in those collecting ducts. That's the only time that they're actually going to filter water back into the bloodstream. How about this passive tubular reabsorption of solutes? So we need, as more water gets reabsorbed, we also need to reabsorb solutes. More water gets absorbed, it creates a gradient for solutes. And as this gradient gets created, it drives the solutes back into those capillaries, those peritubular capillaries. We can reabsorb fat-soluble substances, ions, urea. They tend to follow the water into those peritubular capillaries, down their concentration gradient. So an area of high concentration to that area of low concentration. This is why some lipid-soluble drugs, even pollutants, because we're creating that concentration gradient, this is stuff that we should be excreting. But as we're creating this gradient, they start to get reabsorbed. And these environmental pollutants, lipid-soluble drugs, they can start to cause all kinds of problems in our system. So here is this entire process happening in the proximal convoluted tubules as we try to move sodium. We have the sodium potassium ATPase pump that pumps 3 sodium out per 2 potassium back into the cell. And as we pump sodium out of that cell, it gets reabsorbed back up into the bloodstream. We also have water that travels through these aquaporins. These aquaporins are little channels that pump water along. We have diffusion of different substances that paracellular route by passive transport or diffusion. We have different transport proteins that are going to move sodium, glucose, amino acids, and some ions and vitamins through the cell as well. So as things get filtered out of the blood, we have different transport mechanisms to reabsorb almost every substance. There is some substances that we cannot reabsorb. So we have different carriers for solutes. Sometimes they get excreted in the urine when they shouldn't, like hyperglycemia. If you have too much glucose in your blood, it's going to cause you to excrete glucose into the urine. This is actually a sign of diabetes because we should not be excreting any kind of glucose whatsoever into our urine. We do not want to excrete glucose. Our proximal convoluted tubules is actually where we do most of our reabsorption. Glucose, nutrients, amino acids, sodium, water, ions, uric acid, and about half of our urea is all reabsorbed in that proximal convoluted tubule. So anything that gets filtered out, majority of it gets filtered back in. During that nephron loop, down and back up. As we're going down, we can get rid of water. When we're coming back up, we can get rid of solutes, but not water. We have that thick and that thin segment that I pointed out in those pictures towards the beginning. The thin segments has more passive sodium, while that thick segment, we have symporters. One sodium and two chloride ions going in the same direction, out. We have sodium hydrogen antiporters going in opposite directions. So if I have a channel, a symporter, going to allow sodium and those two chlorides go in the same direction versus an antiporter. We're going to pump sodium one direction, hydrogen in the opposite direction. During that thick segment, some sodium can pass into the paracellular route during that ascending limb. So that distal convoluted tubule and collecting duct. This is the last portion of where things can get reabsorbed. So that distal portion of the convoluted tubule and collecting duct is hormone regulated. So antidiuretic hormone, we looked at that at the endocrine system. Our principal cells, they can put aquaporins so we get more water reabsorbed. The higher the antidiuretic levels, antidiuretic hormone, the more water we have reabsorbed. The lower, the more water we excrete. Aldosterone. They work mostly in the collecting ducts. They will work in the distal convoluted tubule. They help to get those sodium and potassium channels. And that sodium potassium ATPase to get sodium reabsorption. And when we reabsorb sodium, we reabsorb water. Our goal is to have very little sodium leave our system. If we did not have aldosterone, we'd lose about 2% of our sodium a day. And if we lose about 2% of our sodium, we wouldn't survive. So aldosterone increases blood pressure and decreases potassium levels. That is its main job. Atrial natriuretic peptide and parathyroid hormone. Atrial natriuretic peptide is going to reduce the amount of sodium we have in our blood. We decrease sodium, water follows sodium, so it's going to decrease we're going to excrete more water because to decrease the blood volume. When we decrease the blood volume, we decrease our blood pressure. Parathyroid hormone acts on those distal convoluted tubules to reabsorb calcium. Remember that parathyroid hormone acts to retain calcium into our system, whether it is to stimulate the osteoclast cells of the bone to take up some bone to get calcium into the bloodstream, or reabsorb it via the kidneys. So this whole table summarizes tubular reabsorption and secretion, what gets taken up where, and what gets excreted out again and where. And here's all the different parts: the proximal convoluted tubule, what's reabsorbed and how; the nephron loop, what's reabsorbed and how; distal convoluted tubule and the collecting ducts, what's reabsorbed and how. Let's call it a night there. We will continue with the tubular secretion next week. And we may start on the next topic, which is the acid-base balance, electrolytes and fluids, how our body maintains all of that. We'll try to work with some of that next week, as we may start that next week. We'll see. Everything that you need to know for the respiratory exam is in that review PowerPoint that is posted under the respiratory system. If you didn't hear me say it at the beginning, I'm saying it again. It's everything you need to know. I put it all together in one PowerPoint for you. And this test is knowledge-based. It is not application type questions. So it should help some people, hopefully. It's open now, and you have until midnight, or like 11:59 Monday night, to finish it or to take it. Once you start it, you got to finish it. Not one of those take it as you go things, but you know what I mean. So if there's any questions, let me know. Otherwise, have a wonderful night and a great weekend. Thank you. Good night.